my name's Kate Silvester. I started life as an ophthalmologist and got very, very frustrated apologising to patients. At that time, they were waiting 2 years for an outpatient appointment, 5 years for surgery. And I retrained as an engineer, and I made aeroplanes. And I came back into the health service to tackle the queues for cancer in 1999. And ever since then, I've been bashing away at this whole science around manufacturing, which Brunel used to sort out St Thomas's for Florence Nightingale, well, Scutari, in fact. Back in the Crimea, to which St Thomas's was the design. So I was initially given this talk. Would I come and talk about the work that we did with the Health Foundation in 2 trusts, which was to look at the whole problem of a hospital in gridlock. And then I woke up to my shock yesterday, which was that I'd suddenly been reallocated what makes a perfect system or something. And I thought, I can't do that, so you've got this. But it's a very, very interactive session, okay? So the last lot have had great fun running the NHS, and you're going to have exactly the same treatment, as it were. So I'm very grateful to 2 key people for the data, Mel Duffy at South Warwickshire and Paul Harriman at Sheffield, who really should take all the credit for what I'm going to be talking about. So, I was so pleased today when I walked in and somebody showed that at long last our A&E demand, which is there in blue, has been extraordinarily constant. It's going up very, very slightly, but it's actually extraordinarily flat. And if I, as a manufacturing engineer, had that demand to cope with, I would be thrilled. So that's 3 years' worth of demand, flat as a pancake. But what's so revealing is that when you plot the A&E performance against the 4-hour target, is that every Christmas, and especially the last Christmas, it gets worse. So if the demand is flat and the performance is getting worse, what's your hypothesis as to what's going on? And what's more, it's predictably getting worse every Christmas. Yes, what kind of changes?
More celebration.
Sorry?
More alcohol, more celebration.
Keep going down that line. All right? Cheers. Who's swallowing the alcohol?
Well,
The staff. Right. This is Christmas. This is Christmas. This is Christmas. What happens at Christmas? Everything shuts down. And for those of us that aren't there, we're on the sofa with a bottle of booze. Okay? So, today, at long last, we have broken through the paradigm, which is all those wicked patients falling ill. We need to keep them out of here. And we're starting to put the mirror up and realise that it's us that are the problem. So I'm going to get you now to start running the health service. And this is a model, which I'm going to put up in a moment, which was designed by a colleague of mine who's a general surgeon. I don't know why our surgeons seem to be the gang that are getting engaged in this, but Simon happened to do computing science at Cambridge before he did medicine. And whereas I learnt how to design the demand and capacity for a manufacturing system making the wings for Airbus, Simon learnt about demand and capacity in order to run the data through a hard drive on a computer. And it's exactly the same principle. And in fact, Brunel used the same principle to design the system at Renchiori, which became the system at St Thomas's. So the whole principle around this is about understanding demand and capacity of a system. So I'm going to ask you, oh good and great, to run the health service. Okay, so I'll tell you what you've got. We're focused on this whacking great big thing called a hospital, and it's very, very expensive. It's got 780 beds in it. They cost £600 a day to run. And like all good hospitals, it's built next to its cemetery. Okay? We've got patients at home, and they fall sick, and they're going to come up to hospital, because that's the one reliable place you know where you're going to meet somebody who might be able to help you. We've also got an intermediate care service, where we have this lovely idea, which I picked up today, which I thought was super, which was home ward. And we've got the ability to look after 120 home beds in our system. And we've got a care home, which is physically a different location with 250 beds in it. Both of those are a lot cheaper to run. And what I'm going to give you is a simple chart of the daily death rate in the hospital and the cost of the whole of this system. Okay? And our job as NHS managers is to run the system with fewer deaths at better cost. So I'm just going to set the system up, and then you can have a go at running it. Okay, so as the system starts to fill up, we can see our little patients, very sick, coming up to the hospital. Okay, here they are. And the vast majority of them, you'll be glad to know, are going back home again. Okay? A few black dots ending up in the cemetery. And at the moment, 10% of that 60 a day end up in the cemetery. All right? The yellow dots are the patients coming out to be looked after at home in home ward. And the blue dots are the patients going to the care home. The whole of the NHS at the moment is costing us about £5.5 million a day to run. Off you go, let's run it better. Sorry?
So we're on a 4-hour.
You're on a less than 4-hour wait now. Reduce some hospital capacity. Brave man. That's a good suggestion because it's jolly expensive, isn't it? So let's get rid of that out of the way. Come out of the way, you've lost the thing. And I'm going to just pause it. And I'm going to reduce the hospital capacity. How much by? 10%, 700. Okay, I'll call it 600 beds because I can't do the sum. Whoops. It's all right, your check's in the post. Well done, well done, well done. Just what I wanted to see happen. Okay, so the death rate has shot up as a spike, and it's now far higher than it was before at 10%. Okay? Our hospital bed occupancy now is 100%. Our bed occupancy at home care in terms of keeping people going is 71%, and our utilisation of our care home in bed terms is 100% still.
Improve your early intervention.
Improving early intervention, that comes up all the time. What does that actually mean? What are you going to do? What are you going to do? You're going to say, you're not ill.
I think you'd be using the LAS to good effect, or
so how would you know
all the community-based services, so to try and make the interventions at an earlier point, because clearly if people are dying at that point, then they're very, very unwell. So if you can somehow put it in a good infrastructure so that there's greater support.
So that means that when I phone up my GP and I say I'm not feeling very well, the GP says to me, well, you're not feeling very well. How very unwell are you feeling? You can either have an appointment today or you can wait 3 weeks. So what does it actually mean to do that? To make sure that we don't take the risk that actually Kate is sitting on a leukemia and will be dead in 3 weeks.
I think you have to increase your provision of emergency appointments potentially.
And what else?
And also, well, that means that key point that you're then referring on to the appropriate specialist department,
so
if necessary.
Just speed it up or put more in? What's it actually mean?
I think you're speeding up, but you're also so your interventions at an earlier point, and you're signposting to a more specialism possibly. It may not require specialism, it may require other kinds of interventions.
See, so I bet this is called strategy. I don't understand it, sorry. Okay, so what you're saying is that you're going to try and pick up people more quickly before they get into the system. Well, they're currently in the system, they're getting 10% of them are getting assessed and processed the same day. Just 10%. So it's what you're saying is that I'd like to get 20%, let's say double it, assessed within 1 day. Okay? So let's do that. Well done. Okay, you drop the death rate. Okay? Finance director here achieved in dropping the cost, but should end up in jail, in my opinion. And I'll talk about what happened. But you've managed to drop the death rate. So what you've said is for those patients coming into the system, instead of delaying them, and saying I'm going to push the majority out into the future, I'm going to drag them forward, and I'm going to treat everybody as if they were urgent. Okay? And I'm going to provide instantaneous diagnostics. That's the problem for our GP colleagues. You heard somebody today saying, as soon as the pulse oximeter was allowed, it's changed the way he practices. That's the problem our GPs have got. So they have to send somebody to hospital to me with a nice letter saying, please, will you do a chest x-ray? Okay? Very hard being a GP.
Can I just check, is there a flow going from home straight to intermediate care?
Yes, there is a teeny weeny one, yeah. Ah, okay, so this is an interesting idea. This is me phoning up, as I did, and saying, I need somebody to help me look after Mum. She's not very well at the moment. I did that, phoned up. Very nice, instant response. Yes, lovely. We've got your Mum logged into the computer. That was 5 years ago. I've never heard anything since. Mum ended up 6 months in hospital. All right? Why? Because she needed a proper diagnosis and treatment to stop her falling ill. All right? This service is not a diagnostic service. This is a look after you once we've got a plan service. So the important game here is getting the diagnosis and getting the plan and getting it now.
You don't need a hospital to do that.
Exactly.
Provided we've got somewhere with the diagnostics. Okay, so I'm including the diagnostic facility in this thing called a hospital at the moment. But the question is how do we get it out to other places? All right, now the whole of the NHS strategy around diagnostics is what? Centralise it, because you get this thing called economies of scale. So the whole idea is we were going to have 4 eye care laboratories sitting on motorways of England, and all the blood samples were going to go to those. We just have hot labs in the hospitals. Absolutely crackers. We need the diagnostics right here. And if I need a serum rhubarb, I need a serum rhubarb right now. Oh, we only do serum rhubarb 3 times a year in a big batch system in a massive big, no, need it now. That technology is coming. Okay, so carry on. I want you to halve the cost of running the NHS now. We've solved the problem of patients dying, and it's the ones that go home are the vast majority, and it's that group that we're taking the risk with when we don't treat and sort them out straight away. So the whole clever thing in this is you can't change the capacity in the system. You have to change the processes. Now, the equivalent here for my clinical colleagues, this is an ophthalmologist talking about things below the neck, so she doesn't know much about them, is that the capacity, as we see it, is the storage capacity. So it's like, I've lost my bit, it's like having a patient in heart failure, and what we say is, we need more legs. All right? That's what we do. We put legs in, and we take legs out. The bed capacity is not the capacity. The capacity is the human resource available to process the patients. It's the pump capacity. And our pumps, a whole chain of little pumps, are not working in sync. Every single one of them is an AF, so it pumps away for about 4.5 days a week quite regularly, and then, weekend, we stop now. And another pump only pumps twice every week. And a third pump only pumps once a month when it does the assessments for community care. So the probability of you actually escaping this system when you need to is 0. And you end up sitting in storage capacity, either at home, getting sicker, or somewhere in the system. So what we need to do is we need to get the whole thing into sync. So if you really want to start reducing the cost of the system, they are sitting here. But what I'm going to do is start reducing the lead time on this ridiculous process, which takes me 2 weeks to fill in a form to refer somebody for intermediate care. And I'm just going to pick up the phone now. We're going to send Granny home in an ambulance, and she's going to have her assessment at home, and social services are going to get in and actually just provide her with 4 times a day care until she's needed. Now, that tiny group of patients, it's really wired up now. Somebody's going to press a button and send me into space. But anyway, it's a tiny proportion of patients. It's just 2%. But because they have such a long lead time in the system, they occupy a huge number of the bed days. So if I can speed up their process and get it into sync in real time, it has a dramatic impact on the cost. So the first group have a dramatic impact on the death rate, but the second group have an impact on the cost. So now I could safely take your suggestion, which is we can reduce the beds still further. I want you to think about, you can see the destabilisation of the system. Here are Christmases, and this is the death rate. This is the crude death rate of the emergency admissions. So, I come into hospital, the hospital's jammed, I can't get my care on time, and I'm due some antibiotics. The nurses are tangled up trying to find me a female bed on a something ward in time. My antibiotics are late. The harm happens, and I go on to die. My death is recorded at my date of death. But what we've done is captured the deaths and gone back and recorded them by their date of admission. And what you see is horrible spikes that correspond. Now, South Warwickshire have been very good. They've dropped their death rate from around about 6% down to something much more reasonable, to about 4%, and we're due to get their foundation status. And then I plotted this graph. And Glenn Burley was very brave, chief executive, and presented this at the Patient Safety Congress. And Monitor flew out of the audience like a load of vultures and said, you didn't tell us that your death rate was around about 11%. And Glenn said, I didn't know. Because the data I'm given, first of all, is an average for all the year. Second, it's measured by date of discharge or date of death. So the relationship between the flow and the harm is lost. They lost their foundation status. Bang. I was not popular. But they kept going. So, what would you do differently now, having been in here for the best part of half an hour? Nothing. It's okay. Sorry? Yes. Okay. As Bateson said very famously, the system is only as good as its feedback loop. And we all know as doctors what happens to those patients who lose some part of their feedback system. Either it goes or it becomes delayed. They over or underreact. Yeah? Get very sick very quickly. What else would you do differently? Exactly. All right, so we started to publish the killer chart. Every week we updated it, Mel updated it. I just plotted it again into the SPC chart. And then we pulled the whole of the health economy around us into a room, including our colleagues in primary care who had closed Little Hospital that caused the problem. And we started to ask, what happened then that caused this problem? So what was very interesting about that was when I initially put up this data in front of the grand round, the medics said, oh, that wasn't a problem, the patients were going to die anyway. And I thought, what? So what were they doing coming into hospital? So the reaction of the nursing staff and the same meeting was fantastic. That was the worst flu epidemic we have ever experienced. People don't usually die of flu. They can die of flu. They don't usually die of flu. The problem there was all the staff had flu and the families had flu. Everybody had flu. And when I called you in as the consultant body to help, you all told me that it wasn't your on-call. And the HSMR for January and February that year was 128. Game over. Game over. We need to cancel Christmas. How do you cancel Christmas? Right. So with all these capacity plans that are about to start now, I gather, I don't want to hear anything about beds. I want to hear about how we're going to keep that service running as normal across the health and social care system 77365. Christmas is cancelled. Okay? This was the closure of a little community hospital. Now, belonged to the PCT. They were going to save $1 million by closing it down. 1 million a month. And they didn't tell anybody. Now, when you close 40 beds, you're quite effectively blocking 80 beds because you've got to put 40 old people somewhere. And effectively, what it did was completely destabilise the whole of the system. Okay? So, very dangerous thing to do. You have to sit together as a whole health economy and actually work out what's going on. So, instead of doing a plan, do, study, act cycle, what we need to do is a study, and you need to get hold of your daily data and review it weekly, and your weekly daily data and review it monthly. And that's what we do as a whole healthcare system. What do we know has changed in the system to explain the special causes? Sorry?
Change your data collection.
Now we need to adjust our thinking. Okay? What is our theory, our mental model about what's gone on? So our mental model up until now, because we've not had the data, has been, oh, it's those naughty, naughty patients falling ill. We must do everything we can to stop them coming up to see us because we're so overwhelmed. No, it's us. We're the problem. So what are we going to do differently? Cancel Christmas and then start it small. So you make small little tests of change. You don't do it with one great big bang and it all falls over. You start it in one system and you work it up bigger and bigger. Exactly. And that's how we addressed it. So you're testing it all the time. So just to give you some idea of how out of sync these pumps are, this is admissions in red, and this is discharges, daily discharges in green. And you can see that the variability in the discharges is twice the variability of the admissions. Christmas Eve, a miracle happens, everybody gets well, nobody gets well. Right. Hospital fills up, can't get the electives in, another miracle happens. This is weekends. Right. You can just see how out of sync the pump is. This is the daily out of syncness. So this is midnight to 9 o'clock in the morning, that's 5 o'clock there, and that's midnight again. Blue line is the time that the patients turn up in A&E asking for help. And you can see it slowly gets busier, and then at about 11 o'clock it peaks, and it flattens out over lunch. And then about 4 o'clock in the afternoon, 5 o'clock, it starts to fall away gently. But the time that we actually pass the patients through into the main hospital, because when the beds are coming free, is much later. So 2/3 of the sick patients being admitted into hospital are being admitted when there's nobody around. So when I go and follow the poor little junior doctor, he was trying to clerk in a patient who'd gone off with a query subarachnoid hemorrhage, who'd been triaged as not very ill when she'd come into the system at 10 o'clock the previous morning, and he was re-clerking her in at 3 o'clock in the morning. Right. No CT scan, nout. Do you put a needle in somebody's back at that point? Scary question. Okay? So what we've done is we've created this thing called a warehouse, and we now have a Royal College of Warehouse Management, which is a storage unit for storing these patients overnight. That's all it is. Stop kidding ourselves. So when I look at the manufacturing process, you arrive in A&E, you get triaged, don't know what that does, get nursing obs, good move. Get a very good history and examination by a junior doc who usually starts the initial treatment off, sends off some requests for tests and imaging. They may or may not get done. The senior doc is only going to see 1/3 of patients. He's only going to be around at that time. So you're plopped into this great big warehouse. You get some more nursing obs. We're still waiting for the tests and imaging, but nobody can remember if they've gone, been sent, what's happened. Get another history and examination at some point. Then you get a ward round the following morning at 8 o'clock, but there's still no imaging and tests. So now you're into the main system, whether it's in the hospital or outside, with no plan and no diagnosis. All of that is waste. All of it is waste. So this is what it does to a patient's journey. This was an economist, and he came in, big mistake, on a bank holiday Sunday with melena. Quite severe melena. He was feeling pretty tachycardic, and he had cardiac stent, and he was on clopidogrel. Came up, 999. Ambulance agreed, you need me up there, mate. You aren't taking me to Warwick Hospital, are you? Yeah, afraid so. They're the only place that's open. Right. History and examination, 30 minutes. He said it was super. Junior doctor explained exactly what was going on and why he needed to stay, because the junior doctor didn't know when he'd get his endoscopy. He needed examination, 30 minutes work by a junior doctor, 5 minutes in the lab on the call to counter to do your full blood count. He then needed to be nil by mouth for 4 hours before he could have an endoscopy and a breath test. We then should have rested and rehydrated him just to see what his blood volume was and whether he was okay. Somebody should have phoned up the John Radcliffe to find out if we could stop his clopidogrel. We didn't do that. His wife did that on day 5. We then checked his full blood count on day 5, just about before we were going to send him home. It's taken us 5 minutes. We then discovered his haemoglobin was 8.4. He had 2 units cross-matched. That takes 20 minutes of laboratory technician time. He then should have been transfused, 2 units, 8 hours, and then discharged. It took us 8 days to deliver that, and that is 34 hours worth of work. As an economist, he wrote a very sensible letter asking a tax rebate from the healthcare system. We nearly killed him. That's what all that waste is doing, storing patients in bed because the system isn't in sync. So what we aimed to do was to pull this all forward and make sure we've got the same number of staff, but they're now available for a much longer period of time. So the system is actually pumping in sync and we're not having to store patients at every point along the journey. So this is just a quick summary of what we did on both sites. We've matched the junior doctor capacity to the demand. So they just get one clerking. So we've amalgamated A&E juniors with the medical assessment juniors with all the specialist juniors. And then as the demand picks up in the morning, we're measuring the rate as it appears in the A&E reception. And from that, that's called the tack time, using and calculate what capacity you need to meet that rate of demand. So I was doing it on the lunch queue today. So it was a 2-minute cycle time, and the rate hit, we had, I think it was 400 people needed lunch in about 45 minutes. And actually they did manage to clear it. I was quite impressed, but you still had quite a queue. But you can calculate how much capacity you need. So we now pull the juniors down as the day progresses. That's how busy it is to get the clerkings done. Real-time diagnostics. So we work very hard on the portering system and the transport system to make sure that all lab diagnostics are turned around in an hour. So if they're not back in an hour, you know you've got an abnormal blood, basically. 7/7 radiology with real-time reporting. 7/7 acute physicians from 8 until 6 every day. General physicians then take over till 2200, but they can't leave unless everybody is cleared from the system. They've got a plan. Daily consultant ward rounds on all wards on all patients, and the pharmacy turnaround's been pepped up as well. And the key to this proved to be the porters. The porters were doing a kind of loop around the hospital every 1.5 hours, picking things up and then delivering them. And what we've now done is split the porters up so that they're running behind the phlebotomist, picking up the lab tubes. So the lab, instead of delivering huge batches 3 times a day, is receiving the samples in real time. And that's proved to be absolutely key. And the same to the pharmacy. I've stopped there, I think, because you've probably heard enough of me, and let's have a bit of time for questions. Somebody was supposed to shoot me. Yes, 5 minutes. Thank you. Endoscopy. He needed examination, 30 minutes work by a junior doctor, 5 minutes in the lab on the call to counter to do your full blood count. He then needed to be nil by mouth for 4 hours before he could have an endoscopy and a breath test. We then should have rested and rehydrated him just to see what his blood volume was and whether he was okay. Somebody should have phoned up the John Radcliffe to find out if we could stop his clopidogrel. We didn't do that. His wife did that on day 5. We then checked his full blood count on day 5, just about before we were going to send him home. It's taken us 5 minutes. We then discovered his haemoglobin was 8.4. He had 2 units cross-matched. That takes 20 minutes of laboratory technician time. He then should have been transfused, 2 units, 8 hours, and then discharged. It took us 8 days to deliver that, and that is 34 hours worth of work. As an economist, he wrote a very sensible letter asking a tax rebate from the healthcare system. We nearly killed him. That's what all that waste is doing, storing patients in bed because the system isn't in sync. So what we aimed to do was to pull this all forward and make sure we've got the same number of staff, but they're now available for a much longer period of time. So the system is actually pumping in sync and we're not having to store patients at every point along the journey. So this is just a quick summary of what we did on both sites. We've matched the junior doctor capacity to the demand. So they just get one clerking. So we've amalgamated A&E juniors with the medical assessment juniors with all the specialist juniors. And then as the demand picks up in the morning, we're measuring the rate as it appears in the A&E reception. And from that, that's called the tack time. You can then calculate what capacity you need to meet that rate of demand. So I was doing it on the lunch queue today. So it was a 2-minute cycle time, and the rate hit, we had, I think it was 400 people needed lunch in about 45 minutes. And actually they did manage to clear it. I was quite impressed, but you still had quite a queue. But you can calculate how much capacity you need. So we now pull the juniors down as the day progresses, that's how busy it is to get the clerkings done. Real-time diagnostics, so we work very hard on the portering system and the transport system to make sure that all lab diagnostics are turned around in an hour. So if they're not back in an hour, you know you've got an abnormal blood, basically. 7/7 radiology with real-time reporting. 7/7 acute physicians from 8 until 6 every day. General physicians then take over till 2200, but they can't leave unless everybody is cleared from the system. They've got a plan. Daily consultant ward rounds on all wards on all patients, and the pharmacy turnarounds being pepped up as well. And the key to this proved to be the porters. The porters were doing a kind of loop around the hospital every 1.5 hours, picking things up and then delivering them. And what we've now done is split the porters up so that they're running behind the phlebotomist, picking up the lab tubes. So the lab, instead of delivering huge batches 3 times a day, is receiving the samples in real time. And that's proved to be absolutely key. And the same to the pharmacy. I'll stop there, I think, because you've probably heard enough of me, and let's have a bit of time for questions. Somebody was supposed to shoot me. Yes, 5 minutes. Thank you.